Everyone, welcome to Arthritis at Home. I'm Maya, and I'm the program coordinator at Arthritis Consumer Experts. I'm really excited to be joined by Dr. Steve Morgan today to discuss the topic of national pharmacare. He is a professor of health policy at the University of British Columbia. His research focuses on policies to provide universal access to appropriately prescribed, affordably priced, and equitably financed prescription drugs. Dr. Morgan has published over 150 peer-reviewed research papers, received more than $4 million in peer-reviewed research grants, and provided policy advice to governments across Canada and around the world. He has won many awards for his work. Most recently, Dr. Morgan was named the 2019 Emmett Hall Laureate for career-long contributions to health system equity, fairness, justice, and efficiency. First, we're going to talk about the current system for prescription drug coverage in Canada, or how Canadians are currently paying for their prescription medication, and what some of the issues are with this. And then we'll talk about the concept of national pharmacare and how it could be a good solution to some of these issues. Thank you so much for joining us today.
Oh, thank you. I'm glad to be here.
So we're wondering if you can tell me a bit about the current systems that are in place for prescription drug coverage in Canada and what the main issues with this system is.
So that's a good question, and it's a big one. You know, what do we have in Canada? And I think that what Canadians may not realize is that our system of national health insurance is very unique. There is no other country with a universal public health insurance system that does not include prescription drugs within that universal public health insurance system. Now, whereas in Canada, about 95 to 99% of medical and hospital care is funded through what we know of as Canadian Medicare, only about 43% of prescription drug expenditures outside of hospitals is funded through our public drug plans. And those public drug plans, it's not just like an umbrella that covers everyone in the province on equal terms and conditions. Actually, all of our provinces run multiple drug plans that are very specific in terms of benefits for patients of a particular age, a particular income, or with particular diseases, or with particular ratios of needs relative to income. And you might be surprised to know that Canada has 108 different public drug plans in this country. And even as an expert in the area of prescription drug coverage policy, it just baffles me in terms of, you know, the complexity of those programs. And as a consequence, access, at least to public drug coverage in Canada, varies very widely based on, again, your age, your income, your health needs, and frankly, which province you live in. So we have this complexity of the public system, and then we also have a very heavy reliance on work-related employment insurance for extended healthcare, but one of the biggest components of extended healthcare is prescription drug coverage. And access to that is highly varied. There are significant inequities in the system of drug coverage through workplaces, which typically favor people who are employees of large organizations, both private and public, with unionized workforces and working in jobs that are full-time. And as a consequence to that, about 2/3 of Canadian workers don't have private drug coverage. And it is more likely that women, people of color, and people, believe it or not, in middle and low-income jobs are more likely to have none of that private coverage, and therefore they need to rely on that patchwork of 108 different public plans, not all of which cover people.
Yeah, so this is actually something that we see quite frequently, where patients with chronic disease like inflammatory arthritis will actually have to make employment decisions around whether or not their employer provides private insurance that will cover the medications that they need to manage their disease. And also, just to demonstrate what you were saying about differences in drug coverage plans across provinces. So ACE actually publishes something called the Arthritis Medications Report Card, where every year we rank the provinces based on their reimbursement for inflammatory arthritis medications, specifically advanced therapies like biologics. And every year we do see that there's quite significant discrepancies between provinces, where some medications are covered in one province and they're not covered in another province.
I had the good fortune of being an observer at the Citizens Reference Panel on Pharmacare in Canada a few years ago. And one of the things that was really fascinating, and I guess heartwarming in a sense, was that the Canadians that had volunteered their time to spend 5 days grappling with these issues, the thing that upset them most and literally made many of the participants in that program visibly upset was this idea that you could be well covered as a Canadian in one province, but not in another province. And chronic diseases are the area where this disparity is greatest. Because as you know, when you have a chronic disease and a chronic need for an effective medicine, that's not just a one-off thing. We're not talking about, your car getting an fender bender. We're talking about something that happens again and again and again. So people with chronic needs in some provinces, depending on the need that they have, face extraordinary burdens, again, not just once off, but year after year after year. And it's literally, I think it should be a national shame. This is something that we need to recognize as an embarrassment, and is something that is eminently fixable, but it just requires the political will to say that, we're all citizens of one country, we're all residents of one country, and let's make sure that we have equal access and equal protection against not just being able to access the treatment, but the financial burdens associated with it, no matter where you live in this country.
I'd be curious to know if COVID-19 has sort of worsened these issues that we've spoken about, or brought these issues to light in any way.
I think, well, COVID-19, of course, is a global public health crisis that, requires all the measures that are in place and probably more to make sure that we deal with that crisis first and foremost. But it certainly, as a consequence of the economic implications of COVID-19, because of the various measures that have to be put in place, that were put in place back in March and April, and that will need to be put in place again now that we're in the second wave, it has meant that we have had historic high levels of unemployment in this country, high levels of labor market churn, if you will, to use the sort of jargon of my field of economics. And in that context, what happens when you rely heavily on work-related benefits for things like prescription drug coverage is you get a churn in who has coverage and who does not. And just a couple of weeks ago, the Angus Reid Institute, in partnership with myself and a number of other academic experts in the issue of prescription drug coverage and access, we did another national survey to find out what Canadians' experiences are with the affordability of medicines, et cetera. And we found that there has been demonstrable churn in whether people have coverage. Many Canadians actually gained coverage over time in this past year or so, partly because of expansions in public programs like Ontario's OHIP Plus for children and youth, which didn't exist, say, 5 years ago when we last did a major national survey. British Columbia lowered its deductibles for its pharmacare program for families with incomes under $30,000, which did mean many thousands of families then gained coverage. But in net, because of the economic downturn, we estimate that about 1 in 20 households in Canada, nearly 5% of households in this country, lost prescription drug coverage this year alone. And so, on top of a situation where approximately a quarter of Canadian households struggle with the ability to afford medicines, this year has made the problem even worse. And it has made, I think, the need for a national pharmacare even clearer.
If you wouldn't mind explaining to us how a national pharmacare program could work, outlining things like how much it would cost to run, how much it would save, all of the key points.
That's also a very good question, and not one that can be easily answered in just a couple of minutes. But I think for most Canadians, what you need to understand is that the governments of the provinces of Canada run public drug programs already, particularly relatively comprehensive public programs for people who are on social assistance. And this is something that occurred in the post-war era, where Canada was debating whether to have a national pharmacare program. There were numerous reports in the 1930s and 40s that said national health insurance in Canada should be comprehensive, and that is not just hospitals and medical services, but things like home care, dental and pharmacare should be part of that program. And so, provinces did start building pharmacare programs for what we would call vulnerable populations, and social assistance recipients were one of those groups. And older Canadians, people who are over age 65, particularly in the 1970s, 80s, and 90s, were relatively well covered because they were typically people with higher needs and lower incomes. So these programs already exist. They're relatively comprehensive public drug plans for targeted populations. In essence, what national pharmacare is, or what the models of national pharmacare that have been recommended a number of times are, is to basically make programs like that available to all people of all ages and all incomes, just like Canadian Medicare. And so the gist of this is to say, have a universal, comprehensive public drug plan that has relatively comprehensive coverage, that is, covering every medicine that is, demonstrably safe and effective and represents reasonable value for money in our healthcare system. Make sure that those are available at little or no charge to all Canadians. Now you say, well, what is the cost of doing that? It turns out that the cost of doing that, having essentially a single payer comprehensive public pharmacare program in every province with a national formulary that sets the minimum standard of coverage, is actually much cheaper than our system today. The estimated cost of a national pharmacare program is in fact a negative number, because the national pharmacare program would save Canadians more than it would cost government to run. So to give you an example, which is probably the clearest blueprint for moving forward in Canada, it comes from the Advisory Council on the Implementation of National Pharmacare. They said, look, we need to start right away. We need to start right away with investments by the federal government in expensive drugs for rare diseases, which is an area where the provinces have really struggled and where issues around provincial inequities are very significant. And we need to start right away with investing in, as a first stage for the kind of more universal benefit, start with the investment in what we call essential medicines, a list of between 1 and 200 medicines very commonly used by Canadians to address health needs that are affect a large portion of the population. And then the Advisory Council said, within 5 years, make that system cover basically everything, a comprehensive public drug plan akin to what you would find in the United Kingdom or Scandinavian countries or Australia, comparable countries with universal public health systems. And what they said was that in the first year, the government's investment would be a total of $4 billion. And that includes $500 million for expensive drugs for rare diseases and $3.5 billion for the essential medicines program. But that program at its outset was expected to save Canadians enough money that essentially the net benefit to the country would be approximately $1.5 billion to $2 billion in savings per year just from starting there. And that by the time you built up the program so that the federal government was providing provinces with approximately $15 billion a year in financial assistance to run this new national comprehensive public pharmacare program, Canadian citizens, households, and employers would save more than $20 billion a year in return. So in essence, as the Advisory Council made very clear, this would be a net savings to Canada on the order of about $5 billion per year. And that is actually based on fairly conservative estimates of just how much better the prices of medicines can be when you are a single payer and negotiating with manufacturers with actually quite sizable market power as a buyer. So the net story here is that it isn't that it would cost us more, it would actually cost us less to have a national pharmacare program, which creates a tremendous opportunity of thinking about how best to finance that system so that in essence, we're distributing the savings that comes from that kind of system in a way that is fair for Canadians. The other thing to realize is that by doing this, we actually make extended health insurance in Canada more viable, because individual employer groups right now are the groups that are liable for the cost of medicines under private drug plans. And increasingly, and I'm sure your members will be aware of this, some employer groups are saying we're going to put in annual or lifetime maximum benefits under private plans because they can't afford the burden of patients that require high-cost medicines. And that is not their fault as small employer groups. You work for a small or medium-sized organization, particularly in the private sector. That's not a charitable organization. They're not there to provide a public good of access to medicines for all Canadians. That's the job of government. And so by having government take that responsibility on, you actually make it more affordable for employers to continue to offer dental insurance, mental health coverage, vision care, hearing care. I'm looking forward to, for instance, the economic update that might come later this month. In Minister Freeland, we have a very, I think, progressive finance minister in this country. This is an intellectual who has been a journalist, written books about the problems of income inequity in countries around the world. I think she is the kind of finance minister that will say, actually, to raise these revenues, you do not put the burden on low-income families. You raise these revenues, which come from our obligation to fulfill a right to health care. You raise that money from families that can afford it. And I'll be clear, that includes my family. I'm very privileged in terms of having a reasonably high income from being a professional who can contribute, and I should contribute. But families that are earning, $50,000 or less per year should not be bearing a burden of this, because it's those families that that we need to help out, and they're the families that are currently making that trade-off about, do we put food in the fridge or fill the prescriptions for the family, and that's a trade-off no one should have to make. Pharmacare will help with that, and raising the money for pharmacare from a reasonably progressive system will help even more.
As a patient myself and speaking with other patients in the community, I know that some people who live with diseases like inflammatory arthritis may be concerned that a national pharmacare program could potentially limit the number of advanced therapies or biologics available to them, because there would have to be sort of this one big list, let's say, that then medications on that list would be covered. Can you speak to this?
Yeah, no, I understand and sympathize with the concern. I think that there is a phenomena in psychology and policy about what's referred to as a framing effect. We tend to be risk averse when we see that a policy will change. It's a natural human instinct to be worried that policy might be worse than what we already have, and I absolutely sympathize with that. And I think the argument is to ensure and to just demand that governments build this system correctly. We already do run reasonably comprehensive public programs in most provinces with reasonably comprehensive public formularies. And so what I hope, would be asking our governments for is a formulary for a national pharmacare program that meets that at a minimum as a standard of what we would be providing benefits for. So this is one of these situations, people justifiably are concerned, like, what if this system was designed poorly? We would be in trouble. I think that speaks to, we need advocacy to design the system right, because the current system is far worse than even a mediocre universal system. So to argue that we should continue to make a patchwork a system where very many members of organizations like yours who have chronic needs fall through cracks that are absolutely avoidable, that's no solution at all. The status quo, I think, we have to accept as something that is unacceptable. So what we need to be advocating for is a program that is truly comprehensive. And I can tell you, I was a founder of an organization, or kind of a what we called a knowledge translation exercise called Pharmacare 2020. It arose out of a national research network that I ran. It was basically 21 experts in pharmaceutical policy across the country who did work on pharmaceutical policy issues across a whole host of different subject areas. But the unifying theme amongst our members from the very outset of this team nationally was, Canada needs a system of universal and comprehensive prescription drug coverage. We didn't have any bias when we set out on this program as to whether it would be public or private. We just said, universal access to medicines is a human right, and Canada is failing in that regard. Well, one of the things that emerged over the years of working with that group, and then finally when we went out to call to our peers for support for essentially a model that we were asking the government to embrace, we got over 1,300 signatures from experts in healthcare professions and policy, law, ethics, philosophy, etc. We got all these signatures from people on the basis of requesting that the program be truly comprehensive. that the program not be, in the long run, a watered down version of things that we already have, but that the program be something that would be considered a world-class prescription drug benefit.
How can patients help advocate for a program like this?
I think patients and patient groups can become vocal in saying that this needs to be built properly and advocating that their needs be considered. And I think that, there's a variety of organizations that are currently engaged. There's various charities that are currently advocating to support the implementation of a national pharmacare program. The Canadian Labour Council, or Congress, which is sort of the big umbrella group for unions in Canada, they have a very significant campaign underway. One of the things that's important is to talk to people about the issue and to share, whether it's a sense of enthusiasm that this can happen, or to speak with people to get clarification on what government is really thinking about if you have concerns. You've got to get out there, talk to folks, get answers to questions you have, and don't be shy. I think certainly the patient voice is one that is so critical in this kind of policy area that even a letter to your community newspaper, saying, as a patient, these are the kinds of things that I deal with. These are the kinds of struggles that families like mine have to face under our current system. We deserve better. A letter like that to a community newspaper is a powerful tool in engaging your neighbors, in this conversation.
For anybody that, if this speaks to you, we do have a new advocacy section on our website, which has a contact your elected official section, and it has exactly that, where you can create a bit of a template for a letter, puts it into your email, and you can just write in what is most meaningful to you and what you would like to see differences in. So thank you so much for being on our program today, Dr. Morgan. This is super valuable information, and I'm sure that it will inspire many members of the patient community to learn more about this topic, potentially advocate for it or other improvements to the system. So thank you so much, and thank you to our viewers for tuning in. Please feel free to leave any feedback that you have on social media, or you can email us at feedback@jointhealth.org.
Thank you.
Thank you.